Well, this is a procedure, FUE, or Follicular Unit Extraction, that I've been involved with for 17 years now. So it will be impossible for me to go into great detail about any aspect of this procedure in a 20-minute lecture. But what I will tell you is that in 2002, the procedure was described, and every physician in the world said that the surgery was impossible. There was no one to teach us. There was no method. There were no instruments. And so I set out to discover a method, invent the tools, write about the technology, publish, and then teach anyone who was interested in FUE how to perform the procedure. The procedure spread slowly, first in Europe, then the Middle East, then Asia, and finally the rest of the world. Today, FUE comprises over 80% of all hair restoration procedures. And it has made Turkey the hair transplant capital of the world. I'd like to thank the organizers of the meeting for inviting me, Dr. Starademus, Dr. B, and Dr. Stan, and certainly Gina. You know, we all choose a path in life, a career. And for me, it was hair restoration surgery. And the reason I chose this career in 1990 was because the results were so bad. Patients were disfigured, they were embarrassed, and there was no solution in sight. Physicians turned a blind eye to what they were doing. And Dr. McKinney said something this morning, that patients want to have surgery without looking like they had surgery, but that isn't always the case. My objective in my entire career has been to make hair restoration surgery undetectable. And beginning in 1990, I began doing this in the recipient area. And by 2012, we had undetectable results. We actually had them by 1992. And we pushed and pushed with a small group of physicians to change the way hair restoration surgery was performed. Eventually, we succeeded. So there are three types of people in the world. There are those who come to the wall and say it's too high. These are quitters. There are those who come to the wall and try but fail. And there are those that come to the wall and say, no matter how high that wall is, I'm getting over the top. And these are the leaders, these are the innovators, these are the people that are on the faculty of this Congress. We've seen procedure after procedure where innovators have taught us. And there's nothing wrong with being a follower, but we need leaders to advance the field of aesthetic and plastic surgery so that we can push our results into the next century and we can give our patients a better result. And I show this slide only because it took me 5 years of going to the same place in the Bahamas to catch this fish. I was determined to succeed. In 2002, Walter Unger finally recognized that we needed to do something about the donor area. We succeeded in the recipient area, but we needed to get an aesthetically better donor area. But he wasn't quite right that it had been the last decade. It had been the previous 4 decades that we had been butchering donor areas. So I set out in 2002 to discover how to perform FUE so that we could give our patients a much better result. And this is what we were trying to avoid. And many times these scars were much worse than this. So one of the first instruments I developed was a manual handle with precise depth control. And I could change and alter that depth in 0.1 millimeter increments. The next thing I did was focus on the punch. And for the first time, I developed a punch with the cutting edge on the outside edge and an internal bevel. This moved the cutting edge away from the follicles and reduced follicle transection rates. I also focused on making the sharpest punches in the world. And today I still have the sharpest punches in the world, although there is a company named Schraff which has got something very close. And then I created this serrated tip punch, which is exquisitely sharp. It is an engineering marvel, and it's frankly the sharpest thing in the world. We had to develop tools so that we could minimally incise the skin and extract the grafts. This is my ATO, or aid to extraction. And what we accomplished immediately was no more visible scar. And even in patients with thousands and thousands of grafts, we were able to overcome that strip scar. But nobody really cares about the donor area if we don't have results. And we had results. In fact, we had better results, we had faster results, and the rationale was we moved more hair per graft. And we had very low transection rates. And we had result after result, very good results. We had results in transgender patients. We had results in post-radiation scar patients. And we changed the world. Then around 2003, businessmen came to us, and they wanted a hair restoration, but they had to return to work the next week or the next day. And so I came up with the no-shave procedure, which again, everyone in the world said was impossible. Well, it's now the current rage in many locations. So there's something called a complex donor area, and I love the complex donor area because it allows me to vary the size of my punch and target individual follicles, 3 hair groups, 2 hair groups, 4 hair groups, 5 hair groups, and move on and on and on. And by doing this, I get a better aesthetic donor area, and I'm able to move more grafts, and I make smaller recipient sites oftentimes. And we get just, the push is always towards better aesthetics. This is an example of using a small punch to take off a tiny piece of a follicular group where we take a few hairs here, leave one here, take a few here, leave a couple here, and that will result in a better aesthetic donor area. One of the problems with a sharp punch is that because hair grows at an angle, the scar is in a vertical plane. And so it's longer in the vertical axis and thinner along the horizontal axis. In fact, it's longer than the diameter of the punch. And it's all simple math. So to try to avoid this elliptical scar, which has a greater surface area, I came up with the concept of a new punch about 2.5 years ago, where I moved the cutting edge to the outside wall, outside the punch. And I increased the bevel. And it looks something like this. And I put serrations on it. This punch has a lifespan of 30,000 or more grafts. I didn't put a concave surface there for a reason, and I called it the 0T. And as you can see, it's got serrations outside. If you put this directly on the skin, it will not cut you. You have to angle it to cut. And for that reason, it works very well with oscillation and rotation followed by oscillation. Now, this is a machine I developed in 2008. It's got a computer, a controller, and a handpiece. And it's got Bluetooth technology. It counts the grafts. It's a good piece of equipment. And I wrote the computer code to control the machine, and I have an infinite number of options available to me to overcome any scenario. So in this conference, we've been talking about relatively larger surgeries, not the microsurgeries that I do. And for that reason, I had to come up with an understanding that every single patient has a different type of skin. Everyone is different. And I came up with this mnemonic arcades, and everything highlighted here are what we don't want to see because they make the case more difficult. But my machinery and my tools allow me to overcome any obstacle. So this is how the serrated punch works. You meet the skin with the pointed edge, you pull down, you then, moving kind of slow here. It will cut the inferior margin and hopefully leave the superior margin intact. Next. Next. So this is a sharp punch, and you can see that it's in the vertical axis, it's longer incision than in the horizontal axis. And for that reason, it leaves a wider scar. These are grafts cut with my new punch where the epidermis is located only on the inferior aspect of the graft. There's no epidermis superiorly. And so what we're after is not wounds like these round wounds or elliptical wounds, but wounds that collapse. Very tiny incisions like this that really cut down the wounding and help to perform, make the procedure aesthetically better. So it looks more like a needle wound than a punch hole. That's the goal. And these will collapse faster because they're in Langer's lines horizontally, and they're going to leave a better donor area. It's always the pursuit. Now, FUE allowed us to do things that we were never able to do before, one of which was to treat these strip scars. Sure, we could revise this scar, but it's still going to be there. And it may be the same diameter. But for the first time, we could go into donor areas, move FUE grafts into that donor area, and make it so that patient can actually shave his head. And when you combine a little SMP or micropigmentation, they get much better. We also had a big problem with these scars, which are a little pink. Don't really see it as well here. But these are reddish or pinkish scars. There is no treatment for these. You could hit it with a Fraxel laser, but it's still going to be pink. You could take it out, it'll come back pink. But we could graft hair into it, and the skin tone would become normal. So for the first time, we had a solution, not just for treating scars, but treating these pinker scars. Now, invariably, there will be some hypopigmentation in individuals. Some are more prone to it than others. There's a very simple solution, however. We just use some micropigmentation in these extraction sites, and in a couple of hours, this patient has an undetectable result. He just needs to wait for the pink to resolve. In micropigmentation, the key is to deposit the ink in the first 0.5 millimeters. If you go deeper, it will bleed, it will spread, and it will look like a tattoo. Next. All right. Got to go back. Next. Okay. This is a patient that had extractions done in a shaven patches. It's always a bad idea. I told physicians not to do it. In 2004, 2010, the artist robot did this to a patient. We can use FUE and micropigmentation to solve these cases. But, next, what about repair cases? There are thousands, hundreds of thousands of people walking around looking like this. This was a technology in 1990 that inspired me to get involved in hair restoration surgery. This man does not have the donor resources nor the finances to finish this job. He just wants to look like a normal bald guy. So, in 2002, we had two options to treat this man. Next. We could excise the plugs in a strip like this. That would leave a scar. Usually it was a fine scar, but there was no way to finish the job. So I came up with the idea of using FUE to remove the individual follicles that were in the plugs. You can kind of go back to this, and I'll go back one. So this is the concept. We remove the individual follicular units inside the plug to get rid of the problem. This is the surgery. This is about an 8-hour surgery. And I had to do this 2.5 days. And I separate each procedure by a minimum of 6 weeks and typically 3 to 6 months. So this man was able to become a normal bald guy, and it was only possible through FUE. Another example, this is a high school teacher, just wants to be a normal bald guy, and it's possible through FUE. There are individuals that had depleted their donor area. There was inadequate hair on the scalp to finish the job, but they wanted a fuller look. So we used FUE to remove chest hair, back hair, leg hair, abdominal hair, pubic hair, axillary hair. The only place we avoided was the beard at that time. And it worked well in about 1 out of 4 patients. They got more hair. This is a chest hair case. We also had these horribly disfigured individuals. This is from a brandy lift followed by slit mini grafts. He had tattooed his scalp. It turned blue. He had large grafts on the hairline, in the temple points. He had pitting, ridging. It was an absolute mess. So the first objective was to create a clean canvas. Well, to do that, I had to take out the slit mini grafts. Mini grafts are volume. They make the skin move up. It's no different than dropping a rock in a glass of water. So I had to get rid of those. And the way I did it was to use an 18-gauge needle as a scalpel. Suction, good lighting, and high magnification. And I was able to take these out. And here you can see this big clumpy mass of mini graft that's volume. It's like a rock. And I was able to dissect the hair from this and move it up into this top area, which is invariably left bare by the brandy lift. That surgery is now defunct because Dr. Brandy was sued so many times. This is the patient after 6 months. I have a much cleaner slate to work with. All right? I've got a little hair growing up in this area that was bare, and I've done the laser tattoo removal. He's still got some pigment issues, but we've got a much better scalp. He no longer looks like the surface of the moon. Hairline is better, both sides. But the problem with the brandy lift is it takes all the hair on the back and sides of the scalp and lifts it up on the top. And so you get this huge white wall or bare bald area above the ear or supraauricularly. I took out all the grafts that were improper in the temple points, and he was horribly disfigured in the donor area. There was very little scalp hair to work with. Elevation supraauricularly on the left side as well. Well, I went to leg hair, and so I started putting leg hair above the ears. I rebuilt the hairline with head hair. I used leg hair in the temple points, and I added density from the scalp, the chest, the abdomen, wherever I could go. The brandy lift also elevates the nape of the neck, so I rebuilt the bottom part, the nape of the neck part. That was with abdominal hair, and you can see multiple locations of extraction sites. All of these surgeries are like a full day. You can see the leg hair starting to grow at about 4.5 months. On the left side, this is after about 8 months. This is after 8 months on the left side. So the leg hair solved the white wall. Right side again, very natural leg hair grafts. And I discovered that when we transplant body hair from the body to the scalp, it will grow twice as long as it did on the body. And the reason is that you have an increased rate of growth from an average of 0.23 millimeters per day to 0.36 millimeters today. but head hair still grows at 0.42 millimeters a day. Temple points are looking much better than they did. They're filled in. Left side, abdominal hair extractions, these are all healed. Sometimes about 50% will get hypopigmentation here. Nape of the neck, abdominal hair filled in, both sides. Before on the hairline and after. Removal and addition of grafts, and he has a full look again. So, knowing that body hair worked well on only 25% of the patients, I knew I had to find another source. So I finally went to the beard in 2004. And I was concerned about scarring. But by moving into the beard, I discovered a very consistent source of hair. I wrote about it, and the rest of the world started doing it as well, and it changes the game. This gentleman is 91 years old, and he still cares about his hair. So remember, what you do today, these guys are going to care about later on. The scarring on the neck is minimal, and you actually get a slight neck lift by doing beard hair extractions. Now, this is everything I've done over the last 17 years. Not everything, but a condensed version. What I've been focused on the last 3 or 4 years has been regenerative medicine, which is a nice segue into Dr. B's talk. Because hair is the only structure on the body that continuously cycles. It grows, it rests, it falls out, and it regrows. And there is a permanent portion right here. And there is a stem cell niche from top to bottom. And in the anagen or growing phase, there is a proliferation of adipocytes and an increase in circulation. Well, hair loss is nothing more than accelerated aging. That's all it is. So we have to come up with an anti-aging protocol for hair. Otherwise, the patients you treat today in their 20s will come back in their 40s, 50s, and 60s, and they're going to have a lot of hair loss. A lot of hair loss. And you're going to run out of sources. So the most important take-home point Dr. B and I can give you is to start looking for alternative solutions to hair loss. And so this is a quick one, a before and 9 months later, no surgery at all. In this case, it's medical therapy alone. I used a topical finasteride, 2.5% on him, mixed with minoxidil. I started using this product about 4 years ago. The results blew me away. I didn't expect anything, and I got a lot more than I anticipated. But down the pipeline, we're going to have I already have platelet lysate, amniotic membrane, SVX, SVF, and people are not really talking so much about exosomes, but this is the future. And I'm already using it. And I combine it with lots of things, including SVF. Acknowledge my team. Without them, I wouldn't be here. And a big thank you to Aesthetic International for having me. Thank you.
Erkekler için konuştuk ama özellikle saç kaybı yaşayan bayanlar için ne düşünüyorsunuz acaba?
I will do the translation. He said that normally you are talking about men, but what about hair loss for women? What do you think about that?
Well, it's in women, it's a different pattern. They'll maintain the hairline but lose the hair behind, usually, unless they have some sort of hormonal imbalance. In women, it's progressive. And so when we talk about these regenerative processes, the overall objective is to maintain the hair follicle as long as possible. So we can transplant women, but they always get worse. So, I always tell my patients, I can help you, but you must help me help you. And that means that they need to follow a full regenerative protocol, probably annually, even if we do it with transplantation, because hair loss is going to progress. At age 59, 3% of the population is a Norwood 7. By age 70, it's 20%. So the transplants we move from the back to the top are going to thin over time. They're not permanent. There's nothing permanent. All men, all women start to lose hair all over the head at age 35. It's just an androgenic alopecia. It's accelerated. So this protocol is perfect for women.
Yeah, for women it's really perfect. And for women we always recommend this. They have no chance. For men, if they are healthy, if they are young, if they have a good skin condition, we do normal FUE. We don't recommend because we say you don't need. You already have nice tissue. What do you think?
I agree. I think that if we are talking about hair loss is opposite from menopausis and andropausis. So males get bald if they have androgenic alopecia very fast in couple of years. But also in the andropausis to males it goes very slow. In opposite, in women's menopausis goes in couple of years, but the hair losing goes very slow. And the main of problem in females is that it's quality actually of the all school cover. So I think that this regenerative procedure are much more dedicated from my point of view to females than to males. So I agree with you that I wouldn't do in hair transplant in the women's. I mean, I wouldn't recommend. I will better go with multiple regenerative medicine injection.
Well, they're still going to want more hair. I'll give you an example. But first of all, it's critical to catch the hair at the earliest possible time. And there is a test called hair check, and you can predict if someone is going to lose, anywhere on their head just by comparing the measurement in the back of the head with 3 or 4 points on the top. Now, you can predict this is going to go. And I have a famous singer, for example, who was thinning here, and I injected her with exosomes, amniotic membrane, stromal vascular fraction. A complete turnaround, and I can objectively measure the improvement. She's gone from a 60 to or rather from a 90 to 120. So she's got at least a 30% increase everywhere, and in some places 50%. But she still complains. She texts me every week. What am I going to do about my hair? Yeah, sometimes you have to combine a transplant with women because they're your most obsessed customers typically.
I want to invite Professor Gürsel also. He has experience about he prepares stem cell from the hair follicle. Gürsel, come here. Any question from the audience? Yes.
I've got one. What plane are you injecting in?
We try to inject around the follicle.
So in the subcutaneous adipose?
Yeah, yes.
There's one case. We did a case at a live surgery workshop in Manchester. And it was Abert Lamlet, Angelo Trevisano, Pietro Gentile, and they were doing the case. And they injected subgaleal, they injected intradermal, and they injected in the subcutaneous adipose. Mm-hmm. Patient had a small area, and they were using needles, and injecting nanofat. The patient, because it's an oil, and they used a needle, not a cannula, there was a small area of superficial necrosis, and the patient was freaking out. And I'm getting the text on this guy, too. Yes. So it all grew back, but this is what you have to be careful of. You can hit a vessel.
We have seen some cases also because they are looking for what we are doing, but without learn how to do. In our business, in plastic surgery, I think if you know how to do, if you have experience to have an accident, it's already like impossible. But if you don't know how to do, we have many cases they try to do in another place. They inject fat, and there is fat necrosis like lobule or skin necrosis, a lot of bad cases. But if you do every day, like us, we are changing everything. We see what is the problem, what is advantages, what is disadvantages, and we are improving ourselves.
We have another question.
Öncelikle kendisine hoş geldin demek istiyorum. Doktor Peter Cole'a. Şimdi tabii aslında çok soru var bizim kafamızda ama ben tabii çok da vaktinizi almadan birkaç cümleyle sormak istediğimi soracağım. Bizim hem Türkiye'de hem de dünyada çok sıklıkla karşılaştığımız bu body hair transplant dediğimiz vücudun değişik yerlerinden alınan kökleri hastaya transfer etme ile ilgili. Şimdi bunun hakkında ne düşünüyorsunuz? Sizin de zaten yaptığınızı biliyorum. Ama bu köklerin uzamasının ve daha sonrasında da dökülme eğilimi olabileceği ile ilgili bir takım düşünceler de var. Bunu sormak istiyorum.
He first thanked you a lot for coming. He was very happy with your presentation. He has many questions, but he's not going to take your time. He just want to ask about the body hair transplantation and how it grows and how it falls. If you have something to say about that.
Well, as I mentioned, we ran out of traditional sources. So in 2003, we started going to every source on the body. Back, chest, leg, and it grew well in 1 out of 4 patients. And finally we went to the beard. When it grows, it saves lives. It changes the game. But it didn't grow well in 3 out of 4. The beard hair is very consistent. It's very coarse. It's very curly. It covers very well. It's a fantastic source. I would stay off the legs because it will grow well initially in about 25%, but when the patient gets in their 50s and 60s, it falls out. I also would keep the density under 36 grafts per square centimeter because I have a study that yields can be 60%, 66%, below 36, above 36 per square centimeter, the yield falls to 5 or 4%. So keep the density lower. There is a new concept that's just come out to precondition the donor area to get those hair follicles moving, and then precondition the scalp, and then move the body hair up. So stay tuned on that one. The only thing else I would say is anagen hairs will give you a better yield than telogen hairs, but telogen hairs do grow. So I'd focus on anagen hairs, and the way you locate them is to wet shave about 3 days before the surgery. The anagen hairs will elongate. The telogen hairs will remain baby smooth. On the beard, they're almost all in anagen. So I have patients shave either the night before, the day before, or maybe 36 hours before, depending on how fast their beard grows. I don't want it longer than 1 millimeter. I want to be able to get my tool around it so that I can see the angle and not be impaired with how I extract the graft.